Hi, I'm Shree Sharma. I'm a kidney pathologist at Arcana Labs.
And I'm Tiff Caza. I'm also a kidney pathologist at Arcana.
During KidneyCon this past May, we sat down with Dr. Vandana Dua Niyyar, Dr. Bill Whittier, and Dr. Juan Carlos Velez to discuss the renal biopsy adequacy. None of them need any introductions, but still we'll go ahead with a one-line intro. Dr. Vandana is a professor of medicine in nephrology and master physician at Emory University.
And Dr. Bill Whittier is a professor of medicine and nephrology at Rush University Medical Center. Dr. Juan Carlos Velez is the system chair of nephrology at Ochsner Health and a professor of medicine at the University of Queensland Medical School associated with Ochsner Health.
So today we are all here to discuss about kidney biopsies because all of us here are passionate about kidney biopsies. So today, Tiffany and I have a great pleasure to have Dr. Bill Whittier, Dr. Vandana Dua Niyyar, and Dr. Juan Carlos with us. So we are all coming from Kidney Biopsy Academy, and we thought we would record a podcast to discuss all the issues which we are seeing all around. So why did they fly from across the country to Little Rock to make sure people are educated to do great kidney biopsies? So before we dive deeper, our aim today in this podcast is to discuss what is an adequate kidney biopsy. Is that even a problem? Is everyone doing a great job? And what are the different techniques in which the biopsy can be performed? And during the podcast, if we get to know that there is a problem, and it is a problem, then we can decide that what actions we can take to minimize that gap so all of us can do great kidney biopsies so our patient can get the right treatment when they need it. So without further ado, Tiffany, do you think, is there a problem? Like, are we not doing a great job about kidney biopsies?
It's becoming an increasing problem, Dr. Sharma. Overall, we're seeing 27% of all of our kidney biopsies are inadequate, and this impacts not only our diagnosis, but patients are needing to come in sometimes for repeat biopsies. Actually, 40% more when they're inadequate do they need a repeat biopsy. And there's limitations even when we do have an inadequate biopsy, when the patient doesn't get a repeat biopsy. You can't establish chronicity and some other parameters, and the issue is just getting worse with this inadequacy rate doubling in the last decade.
Got it. So, Tiffany, I'm going to ask you a lot of questions because I don't understand many things in the first go. Okay. So when you say 20% of biopsies are inadequate, like if in a layman language, if I get 100 biopsies in a day, 27 biopsies are not good? Is that the right thing?
Yeah.
So when you say inadequate, what do you mean by inadequate? What happened with those biopsies?
Often they're too deep and contain mostly medulla.
Okay.
When the cortex is quite thin, only about a little over a centimeter. And so a lot of times the biopsy traverses too deeply into the medulla.
Okay. So Bill, Vandana, and Juan Carlos, three of you did a workshop just now, and I saw you all speaking a lot about that technique of kidney biopsies. So why do you think this problem has happened, and why do you think this problem is happening now? So Bill, you can go first, and Vandana, we can just move in sequence.
Yeah, thank you. Briefly, I want to say one thing that's been really still improving with the kidney biopsy over the last 50 to 60 years is the safety. So I think there's two issues with the kidney biopsy that are all very paramount, especially when it comes to the patient. Safety, make sure that the patient has a safe experience and there's minimal risk of complication. And then adequacy, what we just talked about. The safety rate over the last years has been very, very stable and improved no matter who does the procedure. So the two different people that do this procedure are nephrologist and interventional radiologist, and that safety rate in all those different publications is about the same. The next part, though, is inadequacy. And I think that this technique, and possibly maybe even using different needles over time, has allowed us to get a little bit more into the inadequate tissue rate compared to when I was training. We did some publications early on, and our inadequacy rate, maybe in 2004, I think it was, when we first published our paper in JASN, was less than 1%. So for 20 years, for it to go up to less than 1%, up to 27%, there's some things that have changed. And that's what I think we need to address.
Yeah. Well, you want to add anything to what Bill said?
So I agree with him. And I think, things have changed and practice patterns have changed. And he as nephrologists have changed. And so when Bill and I and Juan Carlos started doing these procedures, it was the nephrologists who were doing these procedures.
Okay.
But as a specialty, we have moved away from doing biopsies, and it was more informal, and there was a review of the literature. There was a very nice pro and con debate as well that was published in Kidney 360 a few years ago, where people, talked about different perspectives. And the one thing that consistently came up even at that time was that we as nephrologists had started doing less biopsies. And then if you look at the recommendations by ACGME, if you look at the quality or the number of biopsies that you were required to do to graduate was very minimal. It was never specified, but the TPD or the training program director had to certify that they felt that their fellows were capable of doing those biopsies. And there wasn't a number, but most people put that between 6 and around 10.
Got it.
Throughout their fellowship. But when they graduated, they weren't doing as many. And so there was a lot of discussion within the nephrology community. And I will use the word unfortunately, but I do think, unfortunately, we made a decision as a specialty that our fellows do not need to do kidney biopsies to graduate, or do not need to be certified or considered proficient in kidney biopsies to graduate. And as a specialty, I do think that, and of course I'm biased because I'm procedural, but I think that is something that instead of moving towards what I would call a nephrocentric approach, where everything that a patient needs in nephrology should be done by us as nephrologists, that's not happening. And I think that does contribute to the problem.
Okay. Juan Carlos, you want to reflect?
Yeah, well, so many things that go in my mind as I was listening, all of you. I have to start with sharing so upsetting it is to approach a patient, to communicate to the patient that unfortunately the biopsy that was done wasn't good enough to give us a diagnosis, and then we have to repeat it. Some of these biopsies are a very stressful experience for this patient. Some of them have bleeding complications. And here is a situation where the tissue is inadequate, so you don't have a diagnosis, and you have to approach the patient and explain this. Sometimes we're not involved in the first biopsy because the patients get transferred from another hospital, and this is a very stressful situation for the patient and for us to go through that. So we have to find a way to avoid this. And, Vandana, Bill, and I, some of the few nephrologists are still passionate and involved in doing these biopsies. But we have to find ways to connect with our interventional radiologists and interventional nephrologists so that we can get this adequacy back to the 1% failure rate that Bill was quoting earlier.
I get it. So to summarize, we understand that there is a problem. Rate of inadequate biopsies have increased drastically over the period of last 20 years. And as a nephrology team, as a nephrology community, we have not done a great job to encourage our fellows to learn procedures. We have not taught them how to do a great biopsy. And as a result, they are not even aware and they don't understand the intricacies of the biopsies. So what does a good biopsy procedure looks like? Because Bill, you said that safety has increased. And when I think there is a lot of misunderstanding just around the gauge of the needle. Because as a nephrology community, we thought 16 gauge is good, complications are not good, not much. But now when I see people, they think, no, 18 gauge is good. And time and again, there are a lot of publications which have shown the safety of 16 gauge. But we are not able to convey that. Similarly, from the safety point of view, hematoma, that is again brought up a lot of times, and that is made an argument to use different gauge. So can you highlight that? Like, why is that?
Yeah, I would love to. Thanks for asking that really important question. I think that, like I said, the two people that are doing them, nephrology and interventional radiology does an enormous amount of procedures, much so more than a nephrologist. So an interventional radiologist will do procedures on all sorts of organs in the body, not just the kidney, okay? Their standard needle to biopsy any of these organs, whether it's a breast biopsy for a mass or maybe a thyroid biopsy or a liver biopsy, has been always the 18 gauge. Okay, so they have a standard needle that they use in what they think should be all of their procedures.
Yeah.
So they have this automatic reflex of, oh, let me switch and grab my 18 gauge needle no matter what I'm going to biopsy. Okay. The problem with the 18 gauge needle is that it's too thin to get an adequate sample and enough glomeruli. And what you end up doing with the 18 gauge needle to get enough tissue is you go over and over and over and you do more and more passes to try to get enough tissue. Okay. And so what we think is a 16 gauge needle is slightly thicker, 16 gauge is slightly bigger. And if you're able to get 2 passes and 2 cores with that biopsy versus maybe 7 passes and 4 or 5 cores with a smaller gauge needle biopsy, which one there is really safer? 8 different times going in with a needle in one kidney with a slightly smaller needle because they're used to this smaller needle, which they think is safer, or a thicker one less times, okay? And so the data is not perfectly clear in that, but when they've looked at all the different gauge needles across all the boards, and this is summarizing an enormous amount of studies, I'm not going to highlight any one individual one, but in general, the 16 gauge needle has been shown to be just as safe as the 18 gauge needle and actually give you more tissue. Okay, so nephrologists have always been under the belief that the 16 gauge needle is the sweet spot. Okay, we just have to sort of make sure that we communicate that to the person doing the procedure, whether it's a nephrologist or an interventional radiologist, to make sure that they're using the right needle. And sometimes changing these habits, I think, is hard because this interventional radiologist is taking care of the entire body, not just the kidney. So they're so used to using this other needle, it's hard to change practice patterns. So it takes a lot of conversation, a really good relationship with whoever's going to be doing the procedure to make sure that at least they're using that correct needle.
Got it. Thank you. Do you all want to add anything? But not Juan Carlos.
I think what I would just add to that is practice patterns are set by who teaches you.
Okay.
And, in medicine, there's always been a rule, see one, do one, teach one.
Yeah.
And so you do what you were taught. And this is why it's so hard to shift patterns, because we as nephrologists have always used 16 gauge.
Yeah.
Radiologists have always used 18 gauge. And it's always, you're trying to balance efficacy, adequacy. And as a nephrologist, you're very concerned about adequacy because you need that answer to decide what the management of your patient is going to be. As a radiologist, you are doing, your success is measured by the success of the procedure with your complications. So as a proceduralist, I can see that would be what they're looking at. While we as nephrologists, not only do we have to do the procedure safely, but we need it to be adequate because we can then guide our management.
This is a great point, Vandana, which you have brought up. And it resonates with us so much because theoretically, the procedure is successful as soon as you took a piece of tissue out of the body.
Exactly.
But that was not the purpose of that. The purpose was to render an adequate diagnosis. And by diagnosis, I mean a comprehensive diagnosis, which can be useful for prognostic information also. So I think that might be the reason that discrepancy is still existing. Yeah.
And based on what Tiff was sharing earlier, that the great majority of the inadequate specimens contain medulla, is one has to conclude that those biopsies, in those biopsies, the needle went too deep.
Yes.
And again, goes back to what Bill was saying about other organs, right? And every organ has a specific anatomy. And for the kidneys in particular, we're interested in the cortex because that's where the glomeruli are. You cannot apply that to a liver, for instance, right? You have a different. So I wonder, I don't know if what type of training goes in for instance, in interventional radiology in terms of understanding the importance of firing the needle as soon as you hit the capsule as opposed to going deep into the tissue, which you may do appropriately so in all the organs.
When we order a biopsy for interventional radiology to do, the way you have to order it in Epic, which is our electronic medical record, is it says random renal biopsy is what you order. We know a random renal biopsy is just hitting anywhere in the kidney and thinking you're going to be fine. You could go deep. I've got kidney. So it's an automatic bias even in the ordering thing for an interventional radiologist to say, So we need to change our ordering system to say
This is
cortex renal biopsy.
this is a great
We have to have cortex. Now, we all know that. We've been trained as nephrologists. We know that the most important part that we're going for is the cortex. But you're right. If they're going for a breast mass biopsy, anywhere in that mass is what they need to get so they can go deep. So they need to understand, I think, and in some interventional, I'm not saying that they don't understand the kidney anatomy or anything like that. Certainly not. But we want to make sure that they know that the money or the meat of the procedure is the cortex.
You are absolutely right. So something like that, a medical kidney biopsy or a cortical kidney biopsy, something like that will be appropriate. Tiff, you were saying something?
So the nephrologist also gets the feedback that when we read a kidney biopsy, they're taking care of that patient. They're getting the feedback that sometimes the interventional radiologist is not getting. They're not hearing about the quality of the biopsy and that it was diagnostic. They have tissue. They may have a good result that there is no bleeding or other complication, but you're directly receiving the feedback that sometimes is difficult to get at.
Yeah, and the best practice would be then, as a nephrologist, getting that information, and then I could communicate that to the radiologist. But it's another extra step, and it might be not knowing how to tell somebody that they didn't do that great of a job is sometimes an art. And I want to see that everybody in America would be doing that to their colleagues, even though they should, because the patient's always first.
So who should write best practices? You were the past president of ASDEN, and you all are involved with ASN also. So do you think interventional radiology should write the best practices of how to do a medical kidney biopsy, or ASDEN or ASN should write it?
Okay, well,
Open the door.
you open that door. So I would say that, and I think this actually parallels exactly what has happened in interventional nephrology as well. We didn't exist as a specialty, right? The reason why we started is because all the procedures for dialysis access were being done by radiologists who would do the procedure. And because, for example, if you have dialysis access issues, you can always put in a temporary catheter late at night at the bedside. And so they were always the last patients of the day. They were never seen again by the radiologist. And that is why the interventional nephrologist was born, because they know how to do the procedure, but they're also taking care of the patient and they understand dialysis. So you need all of those things to be good and have good outcomes. And I think that's the same place where biopsy is heading, because the problem with us in nephrology is that we are a very cerebral specialty, and we have always idolized electrolytes and acid base, but the majority of our time is taking care of patients with kidney disease and patients on dialysis. And that has always been sort of a stepchild. And we have other specialties, think about a cardiologist. Yeah. A cardiologist does an ultrasound of the heart that's called an echo. Yeah. But could a radiologist nowadays do an echo? It's still an ultrasound that was typically done by the radiologist. So similarly, we as nephrologists, and I keep using this word because I'm very proud of this word, is nephrocentric. Yeah. I really feel that everything that a patient needs in kidney disease realm, from the day they first present to our clinics or in the hospital with AKI, to advanced kidney disease, to the diagnosis of that with a biopsy, to dialysis access, to creation of the access, should be done, whether it's hemodialysis or peritoneal dialysis, should be done by the nephrologist under one umbrella. And again, since you brought in ASDEN, I do think that ASDEN has a different perspective to this as compared to ASN. Okay. So ASN is obviously looking for all the general nephrologists. ASDEN is looking at the proceduralists. Yeah. And we very strongly believe that we should be the ones in charge of our procedures. And if you look at the retention or the recruitment of new fellows, in our time when we interviewed, it was impossible to get into nephrology. Like, you had to really, do something, research, something else to get into a nephrology fellowship. Sure. Now half our spots are left vacant. And that's partly because we have taken, there's a lot of excitement and instant gratification in doing a procedure and having it successful. Not only does it help you manage, but it also, as a physician, gives you a lot of, a lot of validation and gratification from what you're doing. So I think that, I don't necessarily say that ASDEN reflects nephrology's current vision.
Okay.
But in my opinion, that's the way to go, is that there is a group of people in nephrology who are procedurally inclined, who, if they have this option, will take it over. And I think our access centers should not do only dialysis access. They should do everything that's related to what a kidney patient needs, including kidney biopsies. And it's easy. Admit the patient in the morning, have them come for the first procedure of the day, monitor them for till the rest of the day, and then you can let them go. So I do think that there is a place for us to take it over, but that does require a lot of...
It'll be, let me go ahead. What you're saying, Vandana, is the last part is exactly where I think the direction should go. So what happened is the American Society of Nephrology has prioritized this ACGME requirement of the fellowship programs. It is true. If you're not doing it often enough, you shouldn't be expecting people to do this. I understand that. But they have lost focus here. What is the ultimate goal is to provide patient care, good patient care. So if you say nephrologist is not going to be responsible, but we're not going to demand the fellows to learn, and we're going to ignore that the alternative is leading to 27% inadequacy, that is, American Society of Nephrology needs to turn and look in that direction and say, and partner with SCIDN and say, okay, maybe we need to press on the interventional nephrology programs who are heavily invested in vascular access, which is great, but they need to embrace and take ownership of the kidney biopsies. That is, I think, will be a very viable solution. But I don't see it. I think that's where I think it will be a potential path for improvement in outcomes.
And we're not saying everybody needs to be a proceduralist. There are some people who like to work, the joke of the surgeons in the lift, right, in the elevator, and you got to save the hands. But you got to also save, for us, there might be some people who like working with their hands. Sure. And there should be a place for people who do nephrology to have that. Yeah. And there's no reason why we can't provide that under one setting. It's better for the patient. It's better for the specialty. It's a win-win for everybody else.
Yeah, you're right. Yeah.
And that is a lofty goal. And I think that the barrier to it on the nephrologist side is that when we surveyed our fellows that have graduated from our program, where we trained them how to do the biopsies, 95% of them, and these were trained at a place where I've trained them how to do the biopsy, 90 to 95% aren't doing the biopsies anymore. And when we asked them why, they cited several reasons: time, reimbursement, liability, and then why not give it to a proceduralist that's doing procedures all day? So I think your answer to that is there are proceduralists that are doing procedures all day, and they're called nephrologists too, and there's procedures that are interventional radiologists too. The other thing that I think, if you were not going to let interventional nephrology have that, or maybe if interventional nephrology is not going to take that over, and we are having interventional radiology be the ones that are still doing the majority of the procedures, I just think that we need to make sure that we have really good communication with our interventional radiologists so that we make sure they use the right needle, that they know to go for cortex, that they know there are times that a nephrologist knows when we might need a little extra tissue versus a little bit of minimal one. So if it's a focal disease like FSGS, or encapsulitis, which are by nature focal, not all the glomeruli are going to be involved, you might need more than 10 glomeruli to make the diagnosis. So as a nephrologist, we know that. And if I'm the nephrologist doing the biopsy, I'll know I'll need to get more tissue. But if I'm the nephrologist that's not doing the procedure, I really need to make sure that I call that interventionalist and say, hey, this one we need to make sure that we either use a 16-gauge needle if we weren't doing that as the standard anyway, which we should, but also to make sure that they get either an extra core, or really to make sure that we get a diagnosis, because this inadequate diagnosis thing has to go away.
You're absolutely right, Bill. You raised multiple great points. But if I'm not training our fellows, who is going to have that conversation?
I know.
And the part when you said that they're not practicing when they leave is because, again, what we are saying is separate the two. Yeah. Stay be a nephrologist, and you could be a general nephrologist who just sees patients and does everything else. And you could be a nephrologist who does procedures, and they set out time for that. So I agree. Like I will say within our institution as well, the number of biopsies we do has decreased by the ones that we do by ourselves, because if you are seeing 30, 35, 40 patients on the inpatient setting and you have patients who are admitted for a biopsy, that's 2 hours out of your day. So instead of getting out at a reasonable 5, 6 p.m., you're now looking at 7, 8 p.m. if you want to really do your thing. So people hesitate to do the biopsy. And what I think is something like a procedure team that could be there in the hospital that puts in, it doesn't have to be only kidney biopsies, because you may not actually have enough, but you could do kidney biopsies, you could do VASCADs, you could do ultrasounds. There are so many different things that can be done procedurally, and you do have to have dedicated time. So the reimbursement, I think, is not a reason why people don't do biopsy. It is the time that is required that, when we talk about our new fellows, there's this huge, I'm sure you guys have seen that, a huge push on work-life balance. So I think, trying to do that I do think it's not realistic to incorporate it during a regular work day, but if you have specialized time set aside for it because you're on a different kind of service that really does these procedures, there's no reason why we as nephrologists cannot take control. And I think one of the reasons why we've discussed this in the training and workforce is why we are not getting enough fellows within nephrology is because we are losing our procedures. We are giving away dialysis access to radiologists and surgeons. We are giving away our biopsies to someone else. And so there's nothing left that we own except our, cerebralness. I'm talking about sodium left and right. So I do think that we need to expand what we can offer to our fellows. And this is one way of doing that.
So you all are bringing up a bigger problem, though. Because if we don't have trainees, if our 50% of our spots are going vacant, they are not getting filled, then we are not getting who we want. People are not choosing nephrology proactively. So this is just escalating the problem every year then.
Potentially so, although within nephrology, interventional nephrology as a subspecialty is not going down. There's the interest still remains. I'm sure Vandana has numbers on that. But you're right. In the big picture, you are right that as much as I still think that the primary objective of the ideal solution is for interventional nephrology to absorb it, you may say, well, there isn't a population of interventional nephrology in the country that would be able to absorb the biopsy. So you still have to depend on interventional radiology to some degree to do this biopsy, to a large degree. Okay, so what are the options? So, for instance, in my institution, it's a unique situation where we share the biopsies. So we have an opportunity, and we have done occasionally, to communicate with IR, with our colleagues and said, hey, guys, we have a dissecting microscope. We are happy to come down with you with a biopsy because in their routine protocol, they're not doing verification of the tissue. So that's an opportunity for us to communicate so they can do it and improve their adequacy. But, you may also think about another situation where in a rural hospital or in an inner city place in a private practice nephrologist who is not doing biopsy and it's completely all sent to IR. How are we going to get this IR team to incorporate into their practice verifying the tissue? I don't know what the answer is. I think it's just a bigger problem, like maybe even pathology, your team coming, this is the situation, and maybe find ways to train to incorporate into the protocol. And the training may come from pathology, may come from nephrology, but ultimately, if IR is going to do it, they're going to have to be the ones to verify the adequacy of the tissue.
That's true. And we know we can do it. Like the adequacy can be done at the bedside. It can be done with smartphone. It can be done just by looking at the tissue. And today in the Kidney Biopsy Academy, you all have shown that.
We're also hoping from some work from some of these fabulous people at Arcana that even a picture could eventually quantify, using AI, the amount of cortex that is in that biopsy. We're not there yet, but I think that this is some exciting stuff for the future.
I love that, Bill. We are working on that. We have applied for a grant. So now we have an app because we realized we are trying to run that AI algorithm project for last many years. So we collected close to 200 or 300 images, but the quality of images were not good enough that we can deploy the AI algorithm on it. Because AI algorithm is very sensitive to the background. Like what kind of lighting was used? What was the background? Is there any blood? Is there any fluid in the background? And how do you keep the tissue? All of those variables were important. So the quality of the images which we collected was not good enough, and we were just collecting the images from a smartphone. So what we did, we ended up developing an app, almost like an alpha version of the app, where we came up with a handout and said that what a good quality image looks like. And we have started sharing that app with a few of the motivated nephrologists, and they are collecting images. So once we have a good data set of high quality images, next step is to deploy AI algorithm on that. Because the way I think, if we can scan a credit card right now, we can deposit a check online. Why can't I assess adequacy with my smartphone? So, but again, it sounds like a simple problem. It sounds like a simple solution, but it is taking a lot of effort. So we are trying to develop grants for it. We are trying to develop a group which is motivated to do that.
I think there's some hope for the future there, because that might solve the inadequate specimen issue, because then the proceduralist, no matter who it is, will know that they need to keep going until they reach that star mark of, yes, we have enough cortex in your picture. And that might also obviate the need for a pathologist at the bedside, where people may not have enough staffing for that, or, all of us we look at our tissue ourselves and we're able to know, but that's through experience, and a learning person may not have that. So I think this is still very exciting for the future, even though it is slow, and I understand the frustrations.
I completely agree with what Dr. Whittier was saying, but some large universities may have the opportunity for pathology to come for on-site assessment, bring a dissecting microscope, and look at the cores to determine the number of glomeruli that are, perfused, and you see blushes under the dissecting microscope. But a challenge, as you mentioned, with the procedures is that takes planning over time, and you're waiting for someone, and people are, taking time for a tech to come and do that procedure, that having a tool to make it easy and would be preferable.
Oh, yeah.
Well, the app that you suggest doesn't exist yet. There are lenses that can be added to smartphone and give a 10x magnification so that anyone doing the procedure can assess the number of glomeruli pretty well.
And we all can do that by going to his Twitter page, Juan Carlos.
Yeah. No, this is, it's interesting. I go back to when I was a fellow with Vandana, and we were doing a biopsy in the 10th floor of Emory University Hospital, and we would get some sort of cord tissue, and the attending wasn't certain. So we were the transport guy. With the fellow will go down all the way down to pathology, rush in to show to the path technician. They put it in a microscope, and we get the thumbs up. We will rush back to the room, 10th floor again, and say, we're good, we got the tissue. So that was the system that we had at that time.
I'm still doing it.
Okay.
That was the attending, because I let my fellow do the biopsy. Yeah. So they're holding pressure, and now I run down to the lab.
Yeah. So when I started seeing Shree Sharma, you were sharing your iPhone pictures, I got fascinated with that concept. I said, okay, this is something that the IR colleagues can do. And I bought this adapter, the 10X adapter to my iPhone, and it was good. But I kept looking for something better. And there's actually this digital microscope that you buy at Amazon for $40, not even that, like $37. And you can just put it on Wi-Fi, you connect to Wi-Fi, and you can essentially put this digital microscope onto the slide, and you can see the images on your iPhone.
Yeah.
And I take pictures, and I can see the glomerula right there.
Yeah.
So it's very cheap, and it's doable, and anybody could get trained on that. And that has been, we have only presented as a pilot study at Kidney Week, and it was really, the rate of adequacy verification was over 97%. So it's really a nice, and it's so, the idea that you can actually verify the tissue and your procedure is complete, and you're going to obtain a diagnosis is really important.
Yeah, I agree. So over here, we are discussing the adequacy of the tissue. Once I have done the procedure, how can I assess the adequacy of the tissue at the bedside? Using a digital microscope, using smartphone, adding some kind of lens to it. But I want to take a step back. So suppose if I'm a practitioner and I don't do a lot of kidney biopsies in a year, I do like hardly 10, 15 maybe a year. So help me out. What is a good technique for me to remember like few points which I can remember whenever I'm going in to do a biopsy? Because this all sounds very complex for someone, because even in a busy practice, there might be a practice where because people rotate every month, they might not do a lot. So can you give me some tips which I can remember so that when I go to do a biopsy, I do a great job? So what are some of the tips which I can remember?
I would not, first of all, recommend someone who doesn't do that many procedures
Okay.
to do them, because I
Unless they're supervised by someone who is.
unless they're supervised by someone who is, because I do think a couple of things about a kidney biopsy. And of course, again, with my bias as a proceduralist, I do a lot of procedures, but that is why I have a healthy respect for procedures. So even if you do everything right, you may still have complications.
Got it.
And so if you don't really know what you're doing, your risk of complications is exponentially higher.
Okay.
So I would not recommend, because again, why are we doing this? It's for the patient, for us to help find that best management. So if you don't know what you're doing or you only do a few, then again, my true north always is, would I do this to my family?
Sure.
If I would not send my family member to someone to get a procedure by someone who's done 10 a year,
Sure.
then I wouldn't recommend it. So, I mean, obviously there are some tips on what a good kidney biopsy is, but again, those are for the people who are doing them on a regular basis.
Sure.
So I didn't mean to sidetrack.
No, this is very hard. I want to, because there is literature which says that you need to do X number of procedures per year to keep your competency. But unfortunately, we don't have those guidelines. Right.
And that's the one thing that I think, Asden, if we decide to move forward, because this podcast itself has given me ideas, and I want to take it back to seeing how, if we did it for procedures, other procedures like access procedures, why can't we do it for biopsy? So as of now, we don't certify people in kidney biopsies.
Yeah.
We certify people in hemodialysis vascular access procedures. We started certification for ultrasound, in volume assessment, in dialysis access, obviously in kidneys and bladder.
And in diagnostic renal ultrasound.
Diagnostic renal ultrasound, volume, dialysis access. We now offer 3 different certifications. We offer certifications in peritoneal dialysis, but not in kidney biopsy.
Got it.
And so I think that's one thing that we can do to help, is because when you give somebody a certification, what you're saying is this person is doing this in the right way.
Yes.
They are, we are monitoring their complication rate, we are monitoring their adequacy or, efficiency and things like that. So you do want to be able to have some sort of certification. ACGME has never done that.
Yeah.
So the TPDs just had to certify that they felt that their fellows were proficient, but it wasn't based on any criteria.
Yeah.
And so I think that's one thing that we could move towards, because we've already got a blueprint for it based on our hemodialysis vascular access procedures and our peritoneal dialysis procedures and our ultrasound. So there's no problem in adding something else that we might do. The issue is, as a society or as a specialty, we've moved away from these 2 procedures, even placing non-tunneled catheters for dialysis and kidney biopsies. So how do we get everybody excited about that, we are going to offer the certification? Who's going to get certified? Like, who's actually, if we don't train our fellows, this is a dying art amongst our specialty, and it can't die, because this is the only way we can prognosticate and manage our patients, those who have glomerular diseases. And there's a lot of interest in glomerular diseases recently because of the different medications that have come out. So now we have different options for our patients, and we can't just say, I'm just going to defer it to someone else who is doing, so again, jack of all trades. I mean, I shouldn't say that, but if you're doing 100 different kind of procedures, then you're not going to be the best at one kind.
True.
If you're doing only 5 different procedures, you have the possibility to be the best at those 5.
I agree.
And so I feel, again, strongly that this should be with us as nephrologists. And then going back to your question, I mean, we can talk about technical stuff if that's what you still want, but...
No, I want that. But I want some kind of not certification till we reach there. Some kind of guideline. You have to do X number of biopsies, or to feel comfortable and confident, because this is not just one of the other procedures. Medical kidney biopsy is different from others. So how do we make that point?
Yeah, and that's sort of what our workshop was really all about today. The three of us were in a workshop for most of the day, and we were teaching active learners that really wanted to come and get their firsthand experience. And so we probably went over, somewhere between 4 to 5 hours worth of things we want to make sure that they know. But they finished their workshop today. They all did very, very well. But I wouldn't want any one of those people in the room doing a biopsy without supervision tomorrow yet. They still need to be trained in a nephrology program or however interventional radiology has their training, so that they do more and get some more experience under supervision first. I mean, there's different tricks like, we want to make sure that they use a 16-gauge needle. We want to make sure that they use the ultrasound the right way. We want to, there's little things like that. You want to make sure that your patient doesn't have some sort of bleeding diathesis before going into the procedure. So there's so many different things that we covered in the workshop, I think, quite well. That's what it was about. But I think that's going to be kind of hard to just come up with one or two little tricks and then say somebody's ready to go. It's a really comprehensive procedure that...
Yeah, I would say that you kind of twisting your question somewhat, Shree, about the physician who is involved in biopsies every now and then. I think that physician needs to know, number one, is the biopsy indicated? Is it going to change matter? That is the first decision that has to be made, and it's not always easy, right? So the first question is it going to be impact the management of this patient? Number two, is it safe? And we went through during the workshop today about all the risk factors such as high blood pressure and coagulation, etc. We're not, it's a long list. Then the third is actually if it's feasible, right? There are many things happening in the patient. Renal ultrasound, I personally always obtain a diagnostic ultrasound. I need to look at those kidneys on the ultrasound to make sure maybe the patient has an indication, maybe has no blood pressure, but that there is a giant cyst at the lower part of the left kidney. That is a feasibility issue, obviously safety too, but there are things like that need to be taken. So that, I think, even if a nephrologist is not going to do the biopsy, that homework needs to be done before sending the patient to IR, right? Because IR is going to go and it's going to get the tissue. So those are the things that are important. And once you go that, then you go into the technical aspect, which, the great thing today is that Vandana has an approach, Bill has and I have a little different techniques of how we do the ultrasound guidance, how to position the needle. Ultimately, all techniques are safe and valid. You just have to pick the one and kind of be consistent with it.
Sure. So we almost need to come up with a curriculum for the medical kidney biopsies.
Yeah.
I think, there is, you can say a curriculum or you can say, best practices or whatever you need to do, but there has to be a way to not only, when you certify people, you should also recertify them.
Yeah.
So you want to say, okay, well, you can do this now, but let's see after 5 years, can you still do them? And that's what we require if you're a proceduralist at ASDEN, is that every 5 years we do ask for case records, because you do want to recertify people. Because the one thing about getting a competency is getting it and then making sure that you're periodically evaluating it to make sure that that level is maintained.
Sure.
So we're looking at kidney biopsy adequacy at Arcana, and of over 90,000 kidney biopsies, there were no differences.
90,000 kidney biopsies.
It's so incredible.
We're saying that like...
You can't gloss over that. You cannot gloss over
90,000. Keep going.
It's pretty impressive. There were no differences in adequacy between native and transplant biopsies, despite the transplant kidney being more accessible. There was only marginally better adequacy in pediatrics compared to adults. But the biggest factor was the volume of the center of the adequacy rate, just as you brought up.
Yeah. So the higher volume, less
inadequate biopsy.
Less inadequate.
Yeah.
So that's why the competency is very important, as you all mentioned. Because what I have seen just by looking around, so suppose there are 8 or 10 people in a particular department, and the kidney biopsies don't happen regularly at many places. So the person who is doing it is very important, is one of the key. And it's not the same. So because I know that, because in some centers we wanted to launch that smartphone project where you can assess adequacy. And I struggled a lot just to train people because it was not consistent. So that made me realize that you have to come up with a number, like you have to perform, and there has to be someone who owns it.
And actually that's another element that could help into solving this problem? Like, let's say we have at Ochsner satellite hospitals around Louisiana, around New Orleans, and now there is the Lafayette, 2 hours west of us. There's an Ochsner hospital. They were not getting adequate biopsies. Now they actually schedule. They come to New Orleans, to our center, to get biopsy with us. And I think it's a model that could be applied in any large city. You know, you are in Atlanta, big place. So why is a patient going to undergo a biopsy at a small clinic where they're doing one every 8 weeks, right?
Yeah.
They should come to a place where there's a lot of experience and proficiency. So that's another opportunity, I think, to kind of try to manage this issue.
I agree with you completely.
And if they can't come to you, then the other thing that we've started doing in the access world is called train the trainer. So train the people who will do the stuff and train. So instead of training, so let's say we each have fellows. We each have like maybe 7-8 fellows a year. I could either teach the fellows or I could teach one person in that program who will teach the next 20 years of fellows. And so that's one thing that ASN is working with us very closely through TDAT. And we're really trying to train the trainer regionally so that you can not only train them how to do the procedure, but train them how to teach other people to do it. And that's a different skill set.
Yeah.
And that's another thing that could be done. But again, of course, you would need high volume because a kidney biopsy, unless you have something like here, I think what we have here at KidneyCon is something that is, it's nowhere else in the country. I don't think even in the world.
That's true.
And it gives you the option to actually feel as close to what you're going to feel when you're doing the kidney biopsy as possible. Through the different, either the mannequin or the patients or the cadavers. And if we can duplicate this as a sort of a regional train the trainer, so like take it as a roadshow, that would be just fantastic.
That's a fantastic idea. And we can do it here also. Like a roadshow will be like with the likely embalmed cadavers. It might be different for us.
Or unless there are
other places.
Universities that you can pop, with.
Definitely.
Because the thing is, like KidneyCon has become a thing. Like everybody knows about it in nephrology. But it might be good to actually just go somewhere and have, people, because fellows can only go, at least, I don't know, in your centers, but we only pay for fellows to go for one conference per year. So most of them pick some national conference rather than a regional conference. So we could do something different.
But that is a brilliant idea. I think, I would love to do that.
Yeah, that would be great.
Yeah. One question I had regarding technique, and then I'll move on. I asked. Ultrasound versus CT. I'm very confused. Is one superior over the other? Because whenever I talk to nephrologists, they're all ultrasound fan. You know what I mean? They don't even bring up CT. But I see most of our biopsies are CT guided. So can you help me out to dissect that?
You get the answer right there. Where
I will say that the data shows that they are equal in terms of those patients undergoing CT-guided versus ultrasound-guided in terms of complication rate. And the earlier studies that looked at it, adequacy rate was identical too. CT-guided has advantages, and so does ultrasound. So the CT-guided has the advantage of its actually better visualization, and you can detect bleeding at an earlier rate. So if you did a routine CT scan on every single person after the biopsy, 90% of them would have a little bleeding that you would see. Okay. If you do the exact same ultrasound scan after biopsy of using ultrasound, about 60% will only have bleeding because the ultrasound is not quite as good as CT at detecting blood. Okay. However, a little bit of bleeding happens in all the kidney biopsies, so we're not that concerned if there's a little bit of bleeding after every one, okay? So it doesn't mean that detecting it earlier with a CT scan improves your safety. That's not the case. But that is maybe one advantage, that you can have a little bit better visualization. The ultrasound side, though, is that, remember, the kidney moves with respiration. And with the ultrasound, you're really having a live view of it, and you can move it at the same time. The CAT scan or the CT scan is more static. The patient's placed in the CT scanner, they take a picture, they go in, they go back and advance the needle again, they stop, they take a picture again. All of that can actually be changed if the kidney's moving every time they breathe. Okay. So there's different advantages and disadvantages. overall in the literature, they're equal. And then it therefore comes down to the proceduralist's preference. Typically, the interventional radiologist, use CT scan, and typically a nephrologist uses ultrasound. And that might also just be access to what they have in the radiology department too.
Okay.
So I don't think that there's really a big difference when it comes down to it in terms of the literature, in terms of safety or adequacy.
And the reason why we as nephrologists prefer ultrasound is because we have access to ultrasound.
Oh, yeah.
We don't have access to CT scans.
That's true.
And so we are trained, like you said, you do what you're taught. And see one, do one, and we all learned with ultrasound. So
Yeah, and it's actually within radiology, it's not uniform that all do CT guided. I'm sure, I don't know what reports you'll get from different parts of the country, but I've been in institutions where radiology has ultrasound as the first to go approach, and then if not, CT guided, whereas other institutions CT guided no matter what. So even within radiology there are differences, but in general, like Bill said, it's pretty comparable because in my practice, where the instances where I consult a radiology for a CT guided is when essentially the ultrasound is not giving me adequate acoustic windows. If I'm not visualizing the kidney well enough that I can confidently go and hit the lower pole, I'm not going anywhere. I'm not going to touch the base. And usually you're talking about patients, with morbidly obese patients or
Anatomic
factors that just don't get. But it's interesting because one of the participants of Kidney Biopsy Academy earlier asked me, what is your BMI cutoff? And there's not such a thing as a BMI cutoff. Okay. I have patients with BMIs over 60, very large individuals, and I can see very nice kidneys, very easy. You go put a probe in the right place, whereas the next patient might have much lower BMI, and you don't see very well. So I always scan the kidneys, even if the patient has high BMI prior. And if I don't see, then I request radiology to do a CT guided.
Got it.
And keep in mind with the BMI, it's all abdominal fat.
Sure.
So when they're lying on their stomach, you still have, there's not that much fat in the back. You can still get through because all of it is abdominal BAMs. So
absolutely. Sometimes you have patients that are actually athletic with a very thick lumbar muscle, and it is a very deep kidney. The kidneys you don't see very well. So sometimes that's another a factor of anatomy, like Bill said.
Yeah, that is a great point. Tiffany, I have a question for you. What are the problems as a pathologist we face when we come across an inadequate biopsy or not a great biopsy or a biopsy with only one or two lumps?
Yeah, that's a challenge that we see every day. I don't know if we earlier defined what we consider an inadequate biopsy, because overall, in different areas in the literature or to different people, that's different. There is no standard. What we're considering is if you have less than 10 glomeruli or no tissue for IF, we're considering that an inadequate biopsy. But in only a small proportion of those cases do you truly have no diagnosis, like a medulla-only biopsy. In others, you may be able to make a diagnosis, but there are several factors that you won't be able to have some good information, such as chronicity, like the amount of sclerosed glomeruli or degree of tubular interstitial fibrosis that has prognostic impact, or whether you miss active lesions and IgA nephropathy, or someone maybe with ANCA vasculitis. And transplant biopsies are set adequacy criteria as well. And so we may be able to give a diagnosis, but not the best diagnosis. Mm-hmm. And there's also have to work more with the tissue to get there, often in taking deeper tissue sections or doing paraffin immunofluorescence, which is a salvage technique. Overall, we have a 14 times increase in taking deeper sections when you have an inadequate kidney biopsy compared to not, and utilization of over 4 times for paraffin immunofluorescence. And so we're not transferring those costs to the patients, but it is a burden to laboratories, and some labs don't have the capability of paraffin immunofluorescence or some of those salvage techniques in-house.
Yeah, and I want to ask you a question. Since you receive tissue from many places in the country, I understand it, and you can probably explain this the sort of the protocol of cutting the cores, the tissue, because we have encountered cases where the patient was biopsied at a satellite hospital, and we look at the report, and there is 1 glomerulus on the light microscopy, 0 on the IF, and 7 in the electron microscopy component, which makes no sense to me, because it doesn't seem like that's the way you would cut the tissue in terms of the size of each. Could you kind of elaborate on that and share if that is, since you probably provide a kit to the center doing the biopsy, you may not have that issue, but I think it's another point of lack of training across the board. What I'm seeing many cases in which the tissue was not cut optimally to really get to the pathologist ability to make the diagnosis.
Oh, I agree. And when there is limited tissue, it's better to have the good core go for light microscopy and to be put into formalin. You can do salvage for paraffin immunofluorescence, and so if you're limited, it's better to put that tissue for light microscopy. Often in our pathology lab, we're taking that tissue for EM, and the techs are taught under a dissection scope to identify where the glomeruli are, so you're not taking the majority for EM. But some other practices may preserve in glutaraldehyde and need to do that assessment at the bedside, and so it could help to have tools if you don't have access to a dissecting microscope, some of the other tools that you suggested, like lenses, to help divvy that up.
So, Tiffany, you explained me the concept of inadequate biopsies, but you also said we can render the diagnosis on those biopsies by doing deepers or by doing salvage IA. I already got my diagnosis, though. So why are you calling the biopsy inadequate?
It may be a suboptimal diagnosis, though. While we may be able to identify a disease process, you may miss a second diagnosis that is focal, such as focal segmental glomerulosclerosis or focal crescents, a vessel having vascular ejection, for example, in a transplant biopsy. But also the degree of chronicity has prognostic factors. When you look at various disease states, one of the most important factors in progression of the patient's CKD is the degree of IFTA in the biopsy, which isn't often adequate when you have very little cortex to evaluate. So we do these additional salvage techniques to possibly spare the patient from needing another biopsy, but it doesn't mean it was the most optimal.
Got it. So I have a clinical team over here, so I'd ask. So you did a biopsy and you are suspecting ANCA-GN. I had 10 gloms and I didn't say crescents on that, but you are suspecting it. What will you do?
I mean, you're describing cases that I encounter almost every month. And I am particularly, this is an important, common theme for me, because in our center we do heavy urinary sediment microscopy, and I have patients in which I've identified in the urine acanthocytes and red blood cell casts. So I am confident that this patient is having an acute glomerulonephritis, and when I get the biopsy report, before I'm looking at the images on the phone, they report, well, there's just some scarred, glomerular obsolescence of 40%, some focal sclerosis, and maybe an RBC cast in the tubules, but no crescents, no necrotizing lesions. And so for us, it's critical because a crescentic necrotizing glomerulonephritis is going to prompt the clinician to think about an aggressive immunosuppressive therapy. You need to calm the storm and consider your treatment. So it's going to influence my treatment protocol. So I am going to be on the phone calling the pathologist. You sure you don't have more gloms? Could you make deeper cuts? Could you find me a glom with crescent? And I have to kind of use additional information from the biopsy and the sediment to kind of conclude that, yeah, this is probably a crescentic. But it gives you that sense of uncertainty that also you have to go back to the bedside and explain to the patient that this is what I think you have, but we don't have full proof of that, and that doesn't go well sometimes because these are invasive procedures. So yeah, every element of the biopsy, and again, immunofluorescence is sometime whether the patient has some kappa dominance or not is critical for us to decide. So every element of the biopsy, even electron microscopy. Sometimes the light is inconclusive. Sometimes the IF is kind of not clear dominance of anything. You have to wait for the electron microscopy to show those deposits. Boom, now you know with confidence you can go back and ascertain the diagnosis. So, yeah, it is so important.
Yeah. You all want to add anything to it?
I think that the three things we think of when we're doing a biopsy, well, the one thing, of course, is safety, and is it going to change our management? So treatment's always paramount. The second thing is prognosis, and then of course the third is safety that I said. But just getting a diagnosis isn't often enough. We have so many different incredible new trials in the therapeutics for glomerular disease now. There's 3 or 4 different ways that you could argue treatment of ANCA vasculitis as your example, and all of them may be really dependent on something that you're seeing in the tissue. You might be much more aggressive if you're seeing a whole lot of crescents. But if those crescents are possibly focal, like we said, and you may not see them, then you might lean towards another relatively standard approach for the same disease, for the same diagnosis, yet it might not be the right thing for that patient if we miss some of the glomeruli. So prognosis and extent of disease is very, very, very important. And that's in a lot of different diseases, from IgA nephropathy to ANCA vasculitis to focal segmental glomerulosclerosis. And there's so many other things, like in IgA nephropathy, for example, if you didn't get an EM, but you had an IgA patient who happened to have nephrotic syndrome, well, you really want to know if the foot processes are effaced. And in IgA nephropathy, that's not what you're normally thinking, a foot process effacement. But there's nephrotic syndromes and podocytopathies and all sorts of diseases. And if you don't get anything for EM, then you're kind of stuck. Or you may not know that you actually have a fibrillary, because, maybe the DNA, maybe you didn't do DNA JB9 because not all centers do that, and then you don't get EM, and there weren't really any fibrils. So I love that you guys do that, and I love the way that you defined it. In our earlier work, we didn't define it that way. I think for our future work, we really should. We really defined it as QNS. Quantity not sufficient for a diagnosis was our inadequacy rate.
Yeah.
So if I got lucky and got one glomerulus, and it showed a KW nodule, I was able to, we called that a diagnosis even though it was 1 glom. And that might be why also our definitions of percent of inadequate specimens were a little different, because I could then go and tell that patient they had diabetic nephropathy. It might not have been all the information I wanted, but it was enough for a diagnosis. And that's how it was defined back in the day. So it's possible that a more, liberal way of interpreting an insufficient biopsy also is contributing. But as long as you were consistent in your process from the time you collected this to then show that the percent is really still going up, then I think that we really have some work to do on getting better specimens.
I agree with you. And you have to start somewhere. You have to define some things to move. You know what I mean? Like Banff, Oxford classification, ISN-RPS classification for lupus. If you combine all that, so you will get a number from 7 to 10 somewhere. That is when you can do it. But when we start talking about focal disease like FSGS, ANCA, even if you get 20 gloms, you have a chance, a small probability of missing a disease. We have seen cases where we have 30 and 40 gloms, and we didn't see crescents. But when we go deeper and deeper on that, we might end up seeing a glom with 1 crescent. So with focal diseases, the disease can be really focal. So having number of gloms, so as you said, as a nephrologist, you know what you are dealing with when you are going for the biopsy. So you might end up changing your biopsy technique depending on what's going on with the patient from the clinical history perspective. So to me, that knowledge is very important when someone is going ahead and doing the biopsy. And Tiffany, you mentioned the salvage technique for IF. I have seen that people using that. Okay, I didn't submit anything on the IF. You ended up doing salvage technique for IF. But that is also not perfect, because we don't talk about those nuances and problems in day-to-day life. And that is very important when I'm treating a patient, because salvage technique of paraffin IF is not great for anti-GBM. It's not great for C3. It's not great for LCDD. So there are many diagnoses which I might not be able to make if I'm doing immunofluorescence on the paraffin tissue. And paraffin IF is validated according to the center. So it is possible that if you are doing a test on some other center's block, it might be completely negative. So there are a lot of nuances which are involved. On one of the diagnosis and inadequate biopsy, I would like to mention one more thing, that I might end up rendering a diagnosis of membranous nephropathy if I just have 1 glom on IF. But you didn't do the biopsy for that. you wanted so many other things where I don't have a good sample on, like microscopy, and I might not be able to give you that.
There may be segmental scars there that could be focal, and that's going to tell you about prognosis or even longevity of how long that membranous has been there. All those things a nephrologist wants to know, and it's really hard to get from one glom.
I agree with you. So we need to take a pause. So whenever we have an inadequate biopsy, at that time, we need to take a pause to figure out what went wrong here. Rather than reacting, oh, this is an inadequate biopsy, and stopping just there. I think each center needs to figure it out, what went wrong here, what I can do so that my next patient should not go through this. So do you have anything else to add, Tiffany, on that?
No, I completely agree with you. And we have those conversations every day with when we have suboptimal biopsies, or even when there's a quantity that's not sufficient and it may be only renal medulla. And the feedback is really important. And if a nephrologist isn't receiving the feedback, providing that feedback to the interventional radiologist is important too. At Arcana, we've been tracking biopsy adequacy rates among centers, and not to point out, those that are underperforming, but so that they can see how they're doing to their peers, and you'd provide additional feedback and training that may be important.
Okay. There should be some kind of like a national database where we can compare performance across the centers. So that it's not like naming a particular center, but if we can compare performances across the center, and we can decide what is the right way of doing it. We are going to meet for KBA again, KidneyCon, next year. This year was our 10th year.
By next year, this problem will be solved.
I was saying, Bill, say on 15th anniversary, we meet.
There you go. That's a feasible goal.
But what we need to do between this year and 2026, so that we reach a rate of less than 1% when we meet for our 15th anniversary. So what do we need to do in this 1 year? So when we go back to our job tomorrow or on Monday, what do we need to do? Can you all give me some guidance on that?
I think you start. No, that's okay.
Well, I'll just correlate it to things that we've done in other areas in nephrology. And if that's a blueprint that might work, is that we noticed in dialysis access that there's a lot of fragmentation of care. And the person so for example, if you think about it, a nephrologist is a person who discusses with the patient that they're going to start dialysis when they get to that point. And then they're referred to somebody else who then does the procedure and then never really sees them. And then the nurse and the technician in the dialysis unit is the one who's doing the cannulation. And what happens is each part sort of works. There's a little intersection, but they really work independently of each other, and the twain never meets. And so the one thing that we realized to make that work and to make it work better is to have multidisciplinary and interdisciplinary teamwork and feedback. And so what we do now, so the surgeons, we're never seeing for them a successful definition of success of surgery, just like for radiology is getting the procedure with or without the complications, but you're successful when the patient leaves. Whether that's usable or not, and that again correlates to adequacy, is immaterial to them. But how do you make that happen? And so what we did was we created a dashboard, and for us, at a center, we had 15 surgeons.
Okay.
So we de-identified the surgeons, except the one that we were talking to. And we gave them individual feedback on a one-on-one meeting. And I said, this is the data for the rest of the surgeons. This is yours.
Got it.
And then what can we do about it as a team? Because this impacts us and our patients. And that was very well perceived because it wasn't accusatory. They didn't feel that they were being singled out because we said we're doing this to everyone. And so I do think that some kind of a dashboard where you can go back to those people with inadequacies, but say, this center has this volume and this is the outcome. Because I think what you guys have is a great setup. And I will say, honestly, I have tried, because Randy came here. And then for a while, for 2 or 3 years, we didn't have anyone. And I did propose to our, division that we should start sending out procedures. But as a university, you have to have a pathologist. And we have a great pathologist now. But during that time, I think what you all do the way you run the biopsies, but I think the first time I came here, I was just so impressed with the academic discussions on every case where everybody presented theirs is of an unbelievable value. So this has taken kidney pathology to a different level. And now we need to get to that next level. And you have the means because power is in numbers, and you are the best nephropathologist in the country without a doubt. So you can nicely dictate to other people what they need.
Thank you.
And
I think this academic point that she made, because Arcana is extremely academic, is another answer. The way I've dealt with problems before is doing a study on it.
Mm-hmm.
I've dealt with it with science. Come up with a hypothesis. This is and I'm going to examine it myself. I'm going to do the study. And I've had multiple publications in the kidney biopsy arena just in this. What is the adequacy rate? What is the complication rate? And so on and so forth. I think the problem with that is, with what I've done, is that where do I publish my studies? In nephrology journals. Where do you guys read your most up-to-date journal education? It's probably nephrology and pathology. Where do we think that interventional radiologists read? Have they ever picked up a kidney journal? No. Have I ever picked up an interventional radiology journal? No. So I need to, I think, kind of cross over also into the realm of those people that are doing the procedures right now. And if they're still going to be doing them, which I think that's not going to go away, if they're still going to be doing them, let's at least get through education that way, not in a punitive way, but also here's what the data shows. This is the 16 gauge rate. This is the 18 gauge rate. This is the adequacy rate. And I've answered a lot of those with publications and then also possibly talks. So communication's always the key. So I'm very lucky that we have a very good communication with our interventional team at Rush, possibly even on a national level. Instead of me going and talking at the ASN or even at the ASDIN in a specific talk to nephrologists, it makes more sense if I also get out there and talk to interventional radiologists as well. So I'm hoping that in the next year that I can even get on some of the speaking conferences for the interventional team. And perhaps one of our next publications could be in one of the interventional radiology journals. And just try to really, in a friendly way, broaden that, overlap that a little bit so that everyone who's doing procedures at least is doing it the right way.
Sure. Sounds good. That is a great plan.
I think, Shree, answering your question, what is the next step? I would say that needs to be a formal recognition of the problem. If you talk to nephrologists in private practice, everybody will tell you the same. Oh, yeah, it's a problem. 11%, 15, 20% of my biopsies don't have any glomeruli. So everybody knows. People talk about it. But it's not coming out in, Jace, Journal of American Society of Nephrology is not publishing an editorial on this. It's not a visible that we're reading about it. It needs to be that. I think the first statement, it could come from us as a group. We say, this is a problem. You have the data. This is data-supported a problem that needs to be, the awareness of this problem is there, but needs to be formally disclosed.
Sure.
Once you present the problem, then you will come up with the best practices. These are the best practices to address the problem. And the next part of that, the execution of that is a huge task, because this is what involves reaching across specialty, across
disseminating also the right audience.
Disseminate, okay, this is our best practices. You guys are doing a fantastic job. Can we work together and make sure that this is what we do? And that, you approach interventional nephrology, you approach radiology, et cetera, and you kind of bring up. But I think we got to start with making this a problem that is on print. And people in this American Society of Nephrology recognizes it. I'm sure, Vanda has been vocal about this for years, and ASN is not. So you're going to edit that too? No?
yes, we'll edit.
Yes. So, and you have published this work earlier, and now that you have more updated data now of the rate is even higher than it was from your publication. I think it might have been 2019.
Yeah, Dr. Walker and some of the many members of the Arcana team were involved in that work, and it was back in 2018, although some of the data preceded that, the inadequacy rate was 14%.
Yeah, no.
Our quantity non-specific rate or non-sufficient rate that you describe is about 4%, but still that's even too high because that's entirely non-diagnostic.
Yeah. Anything you want to add to what we can do in next 1 year to handle this problem?
So I would love some additional feedback of what we may be doing as pathologists as well, because we certainly care about this problem because this is our day-to-day work where we're seeing biopsies and many inadequate kidney biopsies. Things that we have been focusing on is trying to provide feedback, measuring adequacy and keeping data so that we see the trends over time so that we can later report, show that this is a problem. But we rely on you guys for helping to make that an issue to your colleagues and to make change. But the work that you're doing with Kidney Biopsy Academy, all of you, is a great initiative. But it's an initiative that, can impact maybe 24 people a year, and there's a lot that needs to be done at, each institution.
Okay. I need 5,000 kidney biopsy images so that I can develop my AI. Mine is a very specific thing. Please make that happen.
In 1 year, at Arcana, yes. And I don't know if we can do that anywhere else.
Wait, are you guys developing anything? I know in the transplant world, one of my friends, he's in Chicago, John Friedewald.
Oh, sure.
They came up with something that you don't actually have to do an invasive kidney biopsy, and you can just measure, whatever. I know that obviously a lot of pathology here in native as compared to transplant, but is there something going on in your field that would actually get us to the point where we don't even need an invasive procedure like a kidney biopsy? And I'm totally uneducated here, so educate me.
Incredibly educated.
No, on the pathology parts, yeah.
Well, there is work done on many serum and urine biomarkers to hopefully determine whether, AKI may progress to CKD, to characterize glomerular diseases, or to provide more of a precise diagnosis of a glomerular disease, such as some specialized serologic testing, like PLA2R and membrane, for example. And with improvements in having a liquid biopsy over time, I think could very much advance patient care and help monitor disease over time, because you don't want repeat invasive procedures, and to limit that as much as possible.
Because then we were rid of the problem in 10 years.
Yeah. So, what I have seen in the field of diagnostics, we made progress when therapeutics makes progress. So now we have so many options for therapy. Now our next question will be, how do we select patients for that specific therapy?
Right.
So now there is more pressure on pathology to just dissect it out. Because initially, say, breast cancer was one entity. Now we know breast cancer as such is not one entity. There are multiple subvariants of that. Like membranous is a classical example. It was initially just membranous nephropathy. Now we know there are so many antigens, so many types of membranous. That is what is going to happen with the biopsy. And gradually, as we make discoveries on the biopsies, we will make progress on the serum side. We will make progress on the urine side. Because we cannot, as we said, we cannot do multiple biopsies, but I think progress is going to happen gradually. And now it is going to happen much more faster because we have so many options on the therapy side.
And as Dr. Sharma was mentioning, we need companion diagnostics for some of these new therapies to identify who may benefit. Not everyone is going to have the same, underlying pathogenic pathways driving their disease. And so selecting the right therapy for the right patient is, I think, where we're going in pathology.
I agree with you. But precision medicine is going to start with biopsy, though. So we have to fix this issue. But when we meet next year, we should definitely make tremendous progress in addressing that. To summarize, we will try to go to IR. We will try to present our problem. We will try to publish something in the kidney journal also. We will come up with dashboards. I have seen some centers made tremendous progress when they ended up gamifying it. Just as you said, all the people in the practice, they ended up writing their numbers, how many gloms they are getting, how are they doing, and their names were there. And they just made it a lot of fun. And they ended up improving drastically their rates year over year. And we are going to do, as Tiffany said, we are going to collect data more and more for this year so that we can educate our centers so that they can do a better job.
And I think that's the thing, right? Everybody goes into medicine with the same intention.
Yes.
So if you tell me I'm not doing a good job, I would say 99% of people are in medicine are there because they wanted to do this.
Yes.
And it's a vocation. It really isn't, people didn't come in for different reasons. So if you tell them the right way, they will try to do better.
I agree with you. So I think this was a great discussion. Thank you. I really appreciate your time. Hopefully this podcast starts us on a path where we can think about addressing the issue more and more every year and every month, basically, so that when we meet next year, we have some solid solutions and we have made some headway.
Fantastic. Thank you very much for the invitation.